Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 40th episode of Optometry Series. I'd like to thank my team members, Ms. Meenakshi and Ms. Anshika ma'am. Hi ma'am. Hi Meenakshi. Anshika ma'am, so what is today's topic and who is our moderator ma'am?
Okay, so thanks, Gomati. We have already reached the 40th Optometry Series episode, which is a big thing. So today's topic is vision screening strategies. As we are very close to World Sight Day, and we are looking forward to provide sight to a lot of people by a simple means of just giving them refractive errors, and one of the most easiest way to do it by vision screening. So today we have a very renowned optometrist with us, Mr. Saravanan, who is a faculty at Achyuta, and he's been involved in a lot of community activities. So he's going to help us out and direct us through what are the kind of vision screening strategies can be taken up by us as optometrists so that we can reduce or somehow work towards the burden of reducing the vision impairment. So over to the MC for today to introduce Saravanan.
Yes, I welcome Ms. Sharon, the MC.
Good evening, everyone. I am Sharon Sylvester, a second year optometry student at Dr. Agarwal's Institute of Optometry. It's my pleasure to introduce our esteemed moderator for today, Mr. Saravanan, a senior optometrist at Achyuta Eye Care in Erode. He also serves as a faculty member, academic coordinator at the Achyuta Institute of Optometry and heads the Community Eye Care Department at Achyuta Eye Care. We are honored to have you with us today, sir. Now, let me invite our presenter for the day, Ms. Swetha, a third-year optometry student at Dr. Agarwal's Institute of Optometry, to begin her presentation. Over to you, Ms. Swetha.
Thank you, Sharon. Today's topic is vision screening strategies. Vision screening. Vision screening is a quick preliminary test. It is designed to identify individuals with potential vision problems. It focuses on detecting common issues like refractive errors or eye conditions that may require further evaluation. The goal is to ensure early detection and prompt treatment to prevent vision loss. Importance of early detection. This presentation explores optimizing vision screening strategies to improve eye health outcomes, understanding the importance of early detection and intervention that significantly impact the quality of vision and prevent severe vision loss. The primary goal is to identify potential vision problem early before they impact daily activities, learning, or quality of life. Early diagnosis can enhance their patient outcome, reducing risk of severe blindness. Objectives of vision screening. Early detection of refractive errors like myopia, hypermetropia, and astigmatism. Identifying of other vision issues, strabismus, amblyopia, cataract, promote timely intervention and treatment. Target groups for vision screening. According to age groups, the test performs like neonatal period, uh, preschool children, school children, and older age period. Age group for a neonatal period and test for we perform where external eye screening, red reflex test. Frequency once, preferably within 72 hours at birth. For minimum distance and visual acuity threshold is the near vision. Preschool children, age 3 to 5 years old. Distance visual acuity, external eye screening, once typically before starting school. School children age 5 to 18, distance visual acuity external eye screening for every 1 to 2 years. It is better to do for 6 by 12 in each eyes for distance. For older patients, distance visual acuity, near visual acuity, external eye screening, screening for spectacles if minimum near visual acuity threshold is not met and minimum distance visual acuity threshold is met. Every 1 to 2 years. Minimum near visual acuity threshold is better than or equal to N6 in both eyes. Special populations need to be concerned. Children's and geriatrics. Children's with special needs, additional screening for strabismus, amblyopia, and uncorrected refractive error. For geriatric people, cataract screening, diabetic retinopathy screening, and glaucoma screening. Vision and high health at community and primary level. Approach description. It involves vision and eye screening is conducted in communities or settings where access to regular services may be, may be limited. It may take a place in designed community center, example satellite clinic or door-to-door individuals' home or workplaces. Screening may be conducted as a part of integrated community health program and through visited eye care teams. It conducts by vision screening and eye screening is conducted by trained personnel, including community health workers, outreach workers, volunteers, and private and public eye care personnel. Advantages: increased accessibility for underserved populations or communities with limited access to eye care services. Potential cost savings or individuals who may have otherwise have to travel long distance and incur high experience to access eye care services serves as a valuable short-term intervention that promptly addressing and immediate services need to be the population. Screenings conducted at workplace provide proved accessibility for employees and of a particular benefit to those with presbyopia. Disadvantages: potential for limited resources, inadequate follow-up care, and identify vision problems if not integrated into an existing program or eye care systems. Challenges in finding and retaining qualified personnel for screening can often be with limited long-term sustainability due to dependence, usually an external funding, can be uncoordinated, leading to duplication and inappropriate service delivery. Potential for a missed and or inaccurate diagnosis due to limited equipment, diagnostic capabilities, and application of systems and processes. Disruption or suspension of services at health centers due to limited availability of screening personnel and their absence during outreach visits. For school based screenings, it involves vision and eye screening is conducted for school-aged children with an educational setting, either as a part of a school health programs or through visiting eye care teams. And it also conducted by school teachers trained to screen or other trained personals, include community health workers, outreach workers, volunteers, and private and public eye care personnel. Advantages: convenient vision and eye screening for students and teachers with limited access to eye care services. The shift screening of a numbers of students may be cost effective in identifying vision problems and relieve the financial burden on families and healthcare systems. Engages parents and cares in the child health, promoting awareness of regular eye care and facilitating necessary follow-up care. Disadvantages: potential or limited resources and inadequate follow-up care and identify vision problems if not integrated into an existing program or eye care systems. Challenging in finding and retaining qualified personnel for screening. particularly to manage young children as well as potential cost and burden of training teachers as alternative screeners. Potential quality issues such as false positives and false negatives screenings results due to inadequate training of personnel or limited equipment and diagnostic capabilities. Disruption to classroom activities. Primary level. It involves, along with the health services, often other outreach services to community or satellite clinics. It also conducted by qualified personnel including nurse and health workers. Advantages. Increased accessibility in public health care facilities are often more widely distributed, including in rural and unreserved areas. Vision and eye screenings integrated seamlessly into comprehensive primary healthcare services when required, ensuring the holistic approach to individuals' up, overall health and well-being. Often have a strong referral pathways. May be cost effective for individuals as access screening services. Disadvantages. Refractive and optical services are not often included public healthcare facilities. Potential limitations in terms of equipment, staffing, and funding for vision screening programs. Staff often have a committing properties priorities, demanding schedules, and limited appointment time with patients. Awareness and demand for vision and eye screening may be lower compared to specialized eye care centers. National Program for Control Blindness. The strategies of National Program for Eye Care for Control Blindness follows strengthening service delivery for causes of blindness like corneal opacities and corrected refractive error catch-up, developing human source for eye care by approaching NGOs, government hospitals and community health centers and primary health centers, promoting outreach activities and public awareness to enhance the coverage of eye care services in tribal and other unserved areas, village, etc. Campaigns including effective use of media are most important. Vision 2020. The Right to Sight was launched in 1999 by World Health Organization and international agencies for prevention of blindness. It sought to promote a world in which nobody is needlessly visually impaired, where those with unavoidable vision loss can achieve their full potential, focusing initially on certain diseases which are main causes of blindness and for which proven cost-effective interventions are available. According to World Report on Vision, Vision 2020 was pivotal in achieving unified advocacy for key priorities of high health at the global, regional, and national level, strengthening national prevention of blindness programs, committees, and focal points, supporting the development of national eye care plans, and advocating the stronger evidence in the field. Screening methodologies, mass screening programs in schools, workplace, and community health centers. Mobile screening units reaching rural and underserved populations. Telemedicine and digital screening tools using apps or digital system for remote screening. Technologies for screening. Portable screening devices, handheld autorefractometers, and mobile fundus cameras. Digital vision screening tools, vision test app, and online visual acuity test. Artificial intelligence in screening, AI algorithms for detecting diabetic retinopathy, glaucoma, etc. through fundus images. Implementing a successful screening progress by planning on and resources. Define target population, choose appropriate screening tools, allocate resources. Training of screeners, importance of having trained professionals or volunteers for accurate screening. Data collection and follow-up. Use technology to track sensing outcomes. Ensure patients follow through with care. Conclusion. The importance of early detection in preventing visual impairments is emphasized by vision screening strategies. Screening methods should be tailored to be specific need of the target population for optimal effectiveness. Additionally, follow-up protocols are critical to ensure timely diagnosis and treatment, maximizing the impact of screening program. Thank you.
Thank you so much, Swetha. Now I request our moderator, Mr. Saravanan, to add your input, sir.
It's not audible. Am I audible enough?
Yeah, yes, you're audible. Am I audible?
Your voice is very feeble, Meenakshi. Very feeble.
Okay. I repeat again. Thank you so much, Swetha. I request our moderator, Mr. Saravanan, to add your input, sir.
Swetha, first I'd like to thank Dr. Agarwal Institute for giving me an opportunity to rightly get my core experience to the wider audience. I thank my mentor Anshika madam for bringing me here, and my colleagues, Meenakshi ma'am and Gomati ma'am for bringing me here. I also thank my institution for giving me time to share my experience to the wider audience. Swetha, it was a nice presentation. I think most of the things you have covered it. So most of the things you have covered it in a wonderful way. So I like to intervene few things in that. So you said a few disadvantages is there in the schools, screening programs. So firstly, what I like to do is when we start doing a community outreach program, we need to think in two ways. For what we are doing it, it can be only two things. One is for the service, other one is for the marketing. Or sometimes we combine both. Service, which also indirectly a marketing, which gives you revenue for the organization. Fourth type is they get external fund and they do a camp with huge marketing, propaganda, things like that, and wider audience is covered. So as a small healthcare organization or as an optometrist, we will not be able to get fund initially to do a screening. So screening and also permission obtaining from government officials is not so easy. So when you're working under a banner, it's always better to get a permission and do a screening, because our profession still independent vision screening by Indian legal system is not allowed per se. You need to always accompany an ophthalmologist by Indian legal system. But we call it as vision screening. It is even done by an ophthalmic assistant. It can be done by a vision technician. It can be done by a school teachers. It can be done by an optometrist. It can be done by an ophthalmologist. It is all by experience. We call it this as our protocol. But Indian legal system is not in such a way that these all persons are allowed to do a screening. Screening has to be done by a medical resident. Very clear. So I have experience in RAP survey, so regional assessment of avoidable blindness, where we do screening door to door screening. We go and knock each door literally in the villages. We ask them whether you have diabetes, whether you have, what is cataract, whether some of your family members wearing glasses. We check everybody in their family. We take a 6 meter Snellen chart and we move away from 6 meters from their door and we paste somewhere around there and we check screening. That is one kind of screening. The major screening is done in India is whatever you talk about the WHO standards or NPCB. Most of the screening in India is done for cataract, because that is the bread and butter of the organization. They do screening, they do a surgery, and the vision is given back. But most of the times, the prevalence of cataract, in particular, if you look into the prevalence epidemiology, only 37% of the people will be affected with cataract. Majorly affected with 45 to 50% will be refractive errors, uncorrected refractive errors. In that 50%, 90% of the cases will be uncorrected presbyopes. So presbyopes, they don't get corrected itself because they feel the accessibility to healthcare is the far more distance, and the cost of the consultation is going to be higher, and they will not ready to be wasting their one-day wages. They'll not, because someone has to accompany them and come to the hospital, take them, and they need to wait for dilation if needed, and at least 3 to 4 hours, half a day of their wages is gone, and they all come from 100 kilometers, 200 kilometers away from to the base hospital. So the presbyopic glasses, 100 rupees glasses, can be served at the community outreach itself. So most of the times I suggest when optometrist going along with an ophthalmologist, when fundus is seen and the IOPs are seen, if it is only a clear-cut presbyopia after doing a retinoscopy, after doing a refraction, it's better to give the glasses than there itself, because when you do a referral, they will not definitely come to hospital for buying the glasses, because when it comes to the screening, we need to be two things cautious: cost effective, quality. So quality at any cost shouldn't be compromised. It should be cost effective also, because when you look into the indirect cost, all this cost will be included. They need to get a bus, they need to get a bystander or attendant, they need to come to a hospital, they need to wait, get the for collection of glasses one more time, they need to come. So all these things, matter of 1.5 days is gone. When primary health care is absolutely fine, they need not seek the secondary or tertiary eye care. Number one point. And number two, I just had a few questions in the comment. We see that many don't come for referral. How shall we follow them up? So it's a very excellent question whoever is asked, because even today, you take the Pioneerist Institute as Shankar Netralaya, the Dr. Anuradha Madam has published a paper way back. Only 30% of the people who has given glasses has a good complaint. For example, we take this scenario. If today we all optometrists come out of hospital and we do community outreach all over India, we have almost 15 to 20,000 optometrists. We screen everybody. We give glasses. And if you go tomorrow, only 30% people would be wearing the glasses. The blindness cannot be avoided, because the awareness is still not there that glasses, because glasses are still a social stigma. They feel for various reasons they don't wear it. One thing, probably they're receiving it free of cost. Second thing, they feel that productivity of the work is coming down, especially in adult population. Third thing, when they are children, the parental mentality is still, this is not for my child. My child is a gifted child. Why I need to give a glasses? A pair of glasses is not going to correct it. They will go for religious aspect or a non-allopathic treatment to correct the glasses. Even that happens in hospital sectors. In hospitals or in eye clinic or an optometry setup, the complaints to the glasses, even this tertiary setup, it is only 70%. So the next year they come for review, they don't wear the glasses. They feel it is only temporary. They can remove it in next year. So when we talk about the community outreach, it is only 30%. And places like the Western Ghats like E-Road, we hardly see 10% of the complaints. Even we have done a lot of community outreach programs, and I have personally screened almost 2 to 3 lakhs screening in the last of 1 decade. Every year we used to see at least 50,000 school children. We give glasses to the 20% of the refractive errors, but then it is not, they are not compliant with the glasses. So it is only thing you can improve is counseling, recounseling to the parent, especially. You need to niche that his glasses are going to improve his academic, not only his academic, but also his lifestyle also. Because high potential, what we are currently seeing is not myope. We are seeing more of astigmatism, more of keratoconus. So they tend to come under the amblyop very easily. So you need to re-insist them. If not for these glasses, your vision is not going to improve anyway, and it's going to worsen. That I think, and 1 month follow-up through phone call, and 3 month follow-up through phone call, and 6 months surprise visit to the school without pre-informing. You might get a data whether they are using it or not. But to improve compliance, it's again internal discipline, and you need to have a checklist why they are not wearing it. It can be due to various reasons. Like, one thing is they don't like the frame. Second thing, most common thing is their parents would not allow. Third thing is the class friends will make fun of him or her. So fourth thing is they would have broken it, and that information we would not have grasped it. We are just thinking the moment we give the glasses, he has got the vision back and he is wearing it, and we assume that is happening, but usually it will not. Believe me, it will not, because we get a lot of times upset because we give quality frames, quality lenses through fundings, but they don't wear it, and they say it is. But when you go to a surprise visit in the 6 month, they'll keep it in the bag, but they don't wear it. So sometimes the students are very smart that they will cheat the parents. Sometimes parent will be happy to wear it, but the students will not be wearing it. So you need to sit with every child and spend at least quality 2 to 3 minutes why you are not wearing it, and that counseling part might help, or it is improving in our strategies. It is improving in complaints. And you need to pick up one school teacher in every school. For example, if you have 500 to 1000 strength, it is always better to check select 4 teachers. We have a ratio of 300:1 teacher. You need to, especially if it is biology teacher, it's very well because they understand the science better. If it is a physics teacher, it's absolutely fine. You pick up a science teacher, especially higher class of science teacher, and give a responsibility that at least 3 months once we give them the vision Snellen chart. It is just, it cost you around 30-40 rupees for one school. So you give them, let them paste in the staff room whenever a student is coming with any vision problem, or if teacher is finding that the student is making mistakes when they copy from the board or in the presentation, ask them to stand 6 meters apart, or it is easier way if you give a 3 meters ESO Shankar Netralaya's the 3-meter chart pocket vision screener. You need to paste in every classroom, and if they find it difficult, and that time referral can be happen to the base hospital, not necessarily to the private sectors. It can be to the pre-HC primary healthcare sectors, or it can be government sectors. In that way, early detection is happening. Especially this is very successful in government schools when compared to private schools, because private people anyway they will have some amount of awareness, and they are very much accessible to the healthcare in terms of economy. They'll be coming to us at some point of time. When you talk about the government schools, they will not be having enough time for both the parents, because they'll be their daily wages, they'll be working, and they'll not bring the child to the hospital. So those things, it's a hamper to them. So one thing I like to share is, when you talk about the data, the government schools school health program is far more better than the private school. Those eyes are very good eyes because they have a good amount of sunlight exposure, they have good amount of outdoor activities, they have a proper vitamin intake. So those eyes are, I think, very good when compared to the private sectors, because private schools, I'm not talking in various aspects, I'm not talking in only in terms of eye vision. Private schools slightly they need to improve their, those kids need to improve their hygiene in terms of eyes. But when government schools, they're very good. So government schools we will be doing, and we are very happy to see the results. But in private schools, they usually they don't follow what we say. Number one. Number two is, so what kind of changes or prevention can be expected if early screening is done? Okay, so what kind of changes, when we had a similar doubt, because what happens is, when we document the vision, it is 660 or 636, and we come back to hospital, and we wanted to really see how much amblyopia in this, how much non-amblyopia in this, because a patient with -3 and 636, I would not mind, I would not bother so much, because sometime later in their life, they will come after 1 year or 2 years, they will have a vision difficulty, they'll come back to us, we can give the glasses, they will get the normal vision. But by then, after that, I felt, are we missing amblyopes really? Then what we thought is to take the pinhole for every school screening. So that small equipment changed us huge decision making, because a patient less than 612, we always try to measure the vision again with the pinhole. If it is improves to 6.6, then we are slightly bothered. If it is not improving to 6.6, then we call the class teacher, class taking teacher, and we tell them this student or this child has to be seen in a meticulous way, because you cannot miss this child, because we assume this child vision will come down if it is not noticed in another so and so days or months. So we took and went a small pinhole, because if you add small pinhole to your screening tool, you can eliminate so much of amblyopes, turning into amblyopes. And strabismus is the one difficult thing to convince parents, because they say it is lucky eye for their child, it's gifted eye for their child. So to bring the strabismus and get their eyes surgery done, or the prism therapy, it is very, very difficult. And even if you do free of cost under CM scheme, Tamil Nadu CM scheme, it is very difficult. And you need to be also aware of all the schemes which is available by Tamil Nadu. In Tamil Nadu, we have something called KKT, Kalaignar Kannuli Kaapittu Thittam, which means they give free of classes for all the government and government aided school. Same way, if you go up north, there is something called not sure, but Saba SSA scheme, Abhinay Thittam. They have that policy to implement glasses for the government and government aided school. And fortunately, it is only Tamil Nadu which has so many private schools. When you go up north, the literacy also down, and the education system also down. But the government systems are very, very tightened to prevention of blindness, because all these NPCB offices are all over sitting over Delhi. Those systems are very tightened there. But unfortunately, as Swetha has mentioned, who does the screening also matters. There are no huge amount of qualified people over there. So that is how the Swetha has quoted one paper, which is Priya's paper from Arvind Eye Hospital. They have done research in, I think, 2017. They have done in Bangladesh also. What happens is school teachers, you can categorize school two types of school teachers: all teachers in the school, only selected teachers, or only the school teacher who is science background. You can classify. What they've analyzed is, if you teach, what we'll thinking is, if we teach all the teachers, the result is good. But it is the other way. When you select only particular teachers who will feel they are the owners of the children's eyes for the prevention of blindness, then the result is high. Keeping them involved in the project is more successful than just giving a general teaching to the mob audience of all school teachers. That strategy we usually take: teach the school children, and particularly tell the school children what are school teachers, that what are the symptoms, you need to immediately refer the child to the hospital. And referral, you need to have two criteria. Again, answer to the question: either it is emergency referral or non-emergency referral. Emergency referral has to be seen today or one day, because sometimes students comes with conjunctivitis to the school. They will not be aware that this is a conjunctivitis. That time you need to tell the teachers that these are the symptoms of the viral conjunctivitis. Since it is in the next 3 months, it's a rainy season, you need to tell the teachers that these are the symptoms they will develop if it is really conjunctivitis. So many things has to be taught to the teachers. So they will liaise between the hospital and the children's parents. So that way it helps a good relationship between the children and us. And what else you want me to cover? I think most of the thing I covered. So, and I think always remeasure the vision. If you are finding it, if there is no correlation between your retinoscopy and your vision, because I always tell my students to take retinoscopy to the campsite, because you can easily swipe the retinoscopy and see whether the magnitude of refractive error is high or not. So that tool you need to take and go always. And one excuse not to be given is a charge is not there. So always take a chargeable retinoscopy, so you can see 500 to 1000 patient without any hassles. And second thing is, it is not a clinic. You not have a sophisticated place. You need to sacrifice so many things. Few places we go by morning 7 o'clock. We need to open the door until night 7 o'clock. There is no place for restroom at all. You will not be able to go restroom also. So you need to be prepared, because you are going to clear the hunger of those children who are in the need of vision. So you need to keep in mind, it is not a tour trip, or just go and have fun and come back. Okay, one day college is not like that. So you need to be very, very cautious. And how it started my journey is, when we went for camp during my undergraduation, usually we used to write a lot of camp reports. Those time it was a big headache to me, why they asked me to write so many camp reports. Those I didn't realize. But now that I am realizing, those help me to make me more professional, that what is the real need in that particular area, who is the target audience I'm looking for. Sometimes we go to school, but unfortunately the screening for the children will be stopped, because so many public audience will be come and enter into the school, that they need their cataract to be done, they need their watering complaints to be. So you need to address properly whom you're going to screen. We will be going for school children and their parents, but more of cataracts it will be coming. We will not be geared up to that, because we don't take slit lamp for the school screening, but we need a slit lamp or a handle slit lamp or a fundoscopy to for a cataract screening camps. And whatever you talk, cataract is number one for the blindness, and number two is the refractive error. And now that emerging is the diabetic retinopathy. Diabetic retinopathy, you need to be very smart in accessing the artificial intelligence tools, because now that everybody takes the button, the DRS camera or whatever camera gives the diagnosis. But is it validated? Are you really looking to only believe on those reports, or you need to do a fundoscopy and check whether this is an NPD or PDR, whether this referral is needed, or you can wait and observe? Those things you need to finalize it, though machine does the work. One advantage of machine, even a 10 standard pass candidate can be trained and they can go and take the screening, but they cannot interrupt the report. That is where the role of an optometrist comes into in community eye care. You can sit in a place with help of artificial intelligence or the technology. You can sit in a place, we can assess that person and whether he is doing right or wrong. And now that I feel the screening has become, at least awareness has become more after the pandemic of COVID. Before COVID, it is very difficult to get access to the schools, to get permission, things like that. After COVID is totally different. They approach us, and as a government rule, all the central board syllabus education, CBSE schools mandatory to have the eye screening done, dental screening done every year. But how much they are involved, it is different. How much school really doing is different, but it is a government order to undergo every year eye screening to prevent blindness. And always add color vision to your screening strategy, screening protocol, because sometimes when you screen 3 years, third standard, fourth standard kids, they are very responsive to the color vision. You take Dalton, you take Ishwarya, that's fine. Whatever is available in your institute or this, that's fine. But better avoid the online applications that is still not validated. So you do with Dalton or Ishwarya, and if it is color vision is abnormal, take them to the base hospital and do FMD 15 or 100 if available, and educate them. And because you need to find color vision as early as possible, though it is no treatment available, but you need to educate them, because their ambition, if they set the ambition of a profession which needs color vision, it is difficult for taking them back from their ambition. For example, they wanted to become a loco pilot. It's very difficult for them to become loco pilot when color vision is deficient. So always don't use two words in the school screening. It is abnormal. Abnormal is the alarming word you shouldn't be using at all. You should always use recheck at hospital or recheck the vision or additional examination required. You are not allowed to write a document of abnormal, because when the parents see the document, they'll be panic. Or we have not done the comprehensive examination, we are doing only vision screening. Sometimes we go for camps where we do comprehensive examination. Even if we know it is absolutely abnormal, we don't document abnormal. We document its further examination needed, dilated fundus examination needed, opinion is needed in so and so department, cornea, glaucoma, retina, or the neuro-ophthalmology. So it's always better to bring the patient to the base hospital, and you can call the patient once, twice. That's fine, because they shouldn't be feeling the community outreach is converted into commercial. So twice you can call, and you try reaching out to them and explain the condition. If they're free enough, usually they will come to you, and they usually prefer coming on Sundays, so that if your organization is opting a Sunday service, it's better to ask them to come on Sundays, because they all will be occupied. Everybody is occupied with busy work, and they will not leave the wages and come back. And again, you're giving free of cost. They don't even understand the value of free treatment or screening. So this is all about my thing. And when it comes to pediatric eye examination, Swetha has mentioned 72 hours examination, provided if that is a retinopathy of prematurity examination, because usually 72 hours examination, we do only a fundus examination by knowledge. 15 days after which the child comes for a ROP examination, then 45 days, then 3 months. In third month, you can do a retinoscopy, not before that. You can do a third month retinoscopy. If the child turns 1 year, 1.5 years, I always tell my co-practitioner, better avoid CSM, fixation following intellect. Don't do that, because you need to have a measurable, quantifying amount of vision. Do a vision examination or a LIA paddle, something like that. And when you go for a preschool children, when they do a UKG or LKG, now that it's called in different fancy names, when they do a less than first standard, you better do a LIA symbols, HOTV or Sheridan Garden, something like that, so that you can have some amount of vision that is measured, instead of writing CSM, central steady maintain fixation. Because whether central steady maintain is normal or abnormal, then again a big question. CSM is normal, but how much vision the patient has is again a question. Fixation following, yes, normal, but how much vision they have, it is again a question. So when we go, I always focus kids between 2.5 years to 6 years. More than 6 years, I'll be less bothered, because they will be opening their mouth and telling to their parent that I have this problem, that problem. But when kids from 2.5 years to 5 years, when last year I seen results, those were staggering, because so many refractive errors we have picked in the age of 2.5, 3, especially high astigmatism, So high myopia we have picked, but their demand is not such like that. They will go to school, they will play, and they'll have only small amount of written activities. So they won't open their mouth and tell to the teacher or to the parents as well, because nowadays every child born is born with a mobile phone. So they'll have a beautiful time with the mobile phone. Parents also will be engaging their child with the mobile phone. They will not have any other verbal conversation at all. They believe their child, they assume that their childs are healthy enough in terms of eyes. So always screen 2.5 years to 5 years. It's always better to screen. But one disadvantage is it takes huge amount of time. So the moment, for example, when we screen 2.5 to 5 years, 200 kids, in the same time, I can screen 1,000 other higher classes. So that one thing you need to always keep, or I usually get a different slot for checking this pediatric examination. So even if we screen from 6th standard to 12th standard, the number of screening is high, but I won't get, or the organization won't get satisfied until we do a smaller classes, because they are the they need to be corrected as early as possible. So that is our strategy.
Thank you so much, sir. Sir, am I audible?
Yes, slightly. You're audible, but I think I need to have an ear examination.
Actually, there are few questions posted on a YouTube also.
Oh, YouTube. Okay, okay.
Yeah, many of the questions you have answered it. I'll read out the unanswered questions.
Okay.
The first question will be, we also see many color vision deficiencies in screening, but we concentrate on treating the refractive error. So what should we do about the color vision deficiencies?
I think color vision deficiency, we definitely, I don't think many color vision deficiency you can't see. For example, when we do 1,500 in a school, hardly we get 2 to 3 color vision deficiency. So even if you get higher number, it is good you picked up the color vision, but you cannot come to a conclusion that this is a color vision deficiency with only with Ishwarya. You need to ask the patient to come to an hospital, and better always do an FMD15 or an FM100 and come to a conclusion. Then, I'm sorry, then start rehabilitation, especially in terms of counseling. Why you need to give a what job they can seek when they complete their under the 12th standard, what profession they can go into it as per Indian legal system. Those all things you need to do, but nothing much in terms of color vision deficiency you can do. It's always better to screen color vision. I think I've answered that question.
Yes, sir. Thank you so much, sir. The next question will be, what kind of educational awareness can be given to educate about their problem?
Excellent question. I like this because 5 years, 6 years back, I think there is something called Exilor Vision Experience Project we have undergone, 2018, if I'm not wrong. So what they did is, with collaborating with Optometry Council of India, now it is called as Optometry Confederation of India. They have made a beautiful local language posters which will say about what is redness, when you need to do, what you need to do, do's and don'ts for glaucoma, for refractive error, for glasses, for benefits of wearing glasses. All those IEC information education for the patient is posted in the school. What we did is we asked whoever is reading this completely, and when we come back after 1 month time, or whichever classroom is having this poster sticked beautifully without tearing it, you will get a gift, you will get a small chocolate. Like that, we inspire them, they'll read those things, and they usually have this. And now that we have digital media is accessible in all the all the government school itself, the smart classrooms or big TV, in YouTube, the Optometry Council of India has beautifully given videos depicting when is myopia, what is myopia, how it is to be controlled, why you need not use mobile phone, why it is important to put your eyes in the sunlight. All this video is available in local language. You can be from Rajasthan, Gujarati, Delhi, Tamil Nadu, Karnataka, Kerala. It is available in all local language. So you need to take extra 15 minutes time when you go for school screening. You ask the permission of the HM or the principal, saying you show the video to the HM. They will also not be yeah, even my child is using mobile phone 24 into 48 hours. So you need to show that video to the child, and you need to ask that what is shown here, can you please tell me? Then they will repeat at least for next 7 days. They will follow that. So just an additional effort you need to put in showing all those things.
Thank you
And
so much,
always
sir.
it is better if when you're going for a school screening, it's always better you make the curricular, in the school, whatever they write a diary note that tomorrow school screening is going to happen. If your child has any deficiency, please let us know. Tomorrow's experts are coming from so and so hospital, so we can inform them. So in addition to that, ask the teachers to bring their parents if possible, or definitely bring their grandparents, because grandparents are the biggest victims. They show all the mobile phones, things like that, and the children gets affected. Most of the times in my OPD, call grandparents and I make the parents sit outside, because that is the highest level of counseling you can give to give the good vision to the kids, because they give the mobile phones very digital gadgets very often.
Yes, sir. Thank you so much. The next question will be, we see high refractive errors in case of the camp or screening levels, but many of the camps will not follow cycloplegic refraction. So how should we prescribe the high refractive errors?
Excellent. In terms of prescribing aspect, ideally, any drug is not to be prescribed for two things. One is for therapeutic purpose or diagnostic purpose. You are not allowed to use two things. Even if you go with ophthalmologist, you're not supposed to use. So in that time, we have so many clinical skills. You need to brush up on your science, because there is something called Borish delayed. You can do a beautiful technique in it. Even if it is low refractive error, it's always better to perform a Borish delayed refraction. And if you think it is not enough, you want the child to re-examine it at your hospital, it is always better to refer the child at the hospital and do a refraction, and there you can put whatever diagnostic therapy, the drops, and you can re-examine the child. Even, but always what I prefer is, for example, you are getting minus 11, and if you're not confident with this minus 11 or not, you ask someone of your senior to re-examine, and if he or she gets minus 12, then the range is between minus 11 to minus 12. What I always tell is, at least prescribe minimum minus 11, because when you make the child to refer and come back, 99% they won't come back. So instead of giving CF at 3 meter vision, at least minus 11 will take you to 612. So in that range, you can minimize the blindness. You cannot expect for 100% of the community outreach. So in these cases, it is always better if you have an opportunity to prescribe glasses, then and there, you prescribe the maximum best. But you cannot do, for example, minus 11, you cannot do a wrong retinoscopy and give minus 3. That is absolutely wrong. So you need to recheck your seniors. If your seniors is saying, for example, the faculty members, if it is saying minus 12, or somebody else is getting minus 13, the bracket is between minus 11 and minus 13. So you give somewhere between minus 12, then it's fine, because we have burnt our fingers so many times. Very good question, because we thought minus 9, minus 8. It's always better to have a fundus examination done. And once after that, we will give the glasses. We have thought so many times, but unfortunately, those higher powers has never turned back at all. So what we started doing is, we did a fundus examination, and we, okay, no myopic changes, so fundus is absolutely fine. They started giving the empirically minus 8, minus 9. So that way you can at least minimize the blindness.
Thank you so much, sir. And the last question would be, technologies like artificial intelligence, how do they promote or enhance the vision screening?
I I have no experience in it. I am old guy, so old school of thought. I have not utilized any of these technology, especially in terms of school eye health program or in vision screening. We use that for diabetic eye screening or for glaucoma eye screening, because you need to know a lot of nuances, nitty-gritties. You need to have a very skilled person to do this with 90D or with ophthalmoscope. So we use that gadgets for and diabetic eye screening and for glaucoma. When it comes to school eye program, I think we need to start utilizing that, but I have no experience in that. It's always better to adapt to a technology, but I'm old school of thought. I never tried those things. I'll try that and I'll keep you informed. Time consuming, it will be less time consuming. Definitely, that one thing I can say. But how much validation, I cannot ask that software or AI whether it is, whether I cannot give a treatment based on definitely that. Probably a manpower can be shorted. Instead of taking 10 people's, you can take 3 people's, 4 people's, and you can reduce the manpower. and time and efforts. It's always better you need to know what AI cannot do. If you know what AI is doing, then it's fine. What AI cannot do, you should be knowing, because that is where you take a role.
Thank you so much, sir. Anshi ma'am, do you have any questions, ma'am?
I think that was a very, very detailed conversation and presentation and everything we have. So I don't have any questions. I'll just try to wrap up in a short manner what Saravanan and Swetha has tried to explain. That I'm not going to do the strategies. Strategies were well explained by Swetha. So the important points which Saravanan has given us is we have to look for funds, we have to look for permissions, we should plan our screenings, and equipments and logistics are also very important. Again, screening strategies when we are going in for, we should look for whom we are aiming at. So as he rightly pointed out, there are so many uncorrected presbyopes which are there. So, when we plan a strategy, we need to know what is our target and what are we planning to do. So overall, presbyopia, school children, cataract, diabetic retinopathy, all that was covered. Another thing which is important post screening is during the screening, the quality and the cost effectiveness of our screening strategies, and obviously post it, the follow up and counseling. So just doing the screening and giving classes or telling this is the treatment is not enough. We should be following up on regular basis to understand whether our screening is doing any work or not. So thank you, Swetha and Saravanan, for such a detailed discussion on vision screening strategies. Over to you, Gomati.
Thank you so much, Anshi ma'am. And Saravanan sir, that was a detailed explanation. Thank you so much for joining with us today, sir. Thank you.
It's my pleasure.
Thank you. Thanks, Meenakshi. Thanks, Anshi ma'am. Thanks, Shweta. And thanks for the MC of today, Ms. Sharon. And the announcement for the week is DIO's Champions League 2024 is happening tomorrow and day after tomorrow, the most awaited event for the students. So, on behalf of DIO, Dr. Agarwal's Institute of Optometry, and the Optometry Series team, I would like to wish all our students with best wishes. So, let the best team win. So, thank you all. Thanks to all the audiences for the continuous support until today for all the 40 episodes of Optometry Series. Thank you all. We'll meet in the next episode.
Bye bye.